different topic. Okay, when you say immunocompromised, it's slightly different topic, and now comes all your clinical knowledge that comes in for immunocompromised status. It's not something that is easy. So first of all, what would you call as an immunocompromised patient?
The immunocompromised means patient whose immunity is not responsive to the bacteria. The normal patient's immunity is responding. Like
Which patient will say is she immunocompromised?
Patient who is undergoing chemotherapy.
So anyone who doesn't mount or is not possible to mount an immune response, okay, and has a high likelihood of getting opportunistic pathogens other than respiratory core pathogens. When we said respiratory core pathogens, we talked about strep pneumonia, staph, strep pyogens, H influenza, influenza virus, respiratory syncytial virus, coronavirus. We talked about all these things, atypical Legionella, mycoplasma, chlamydia, right? These are called as core pathogens. These are core pathogens. Once we start talking that this patient has got opportunistic pathogens, when it has a chance of opportunistic pathogens, which includes fungus, nocardia, strongyloid, stercoralis, parasites, fungus, mucorales, aspergillus. When you talk about all of these different kind of other pathogens, and they have a high risk for getting opportunistic infections, like herpes simplex, like chickenpox, things like that, they are called as immunocompromised. Clear? You understand why are we differentiating between both of these? Because of the fact that I will need to direct my investigations and treatment towards those also in that particular patient. Are you understanding? That's why they are called as immunocompromised individuals. You understand? So what will be immunocompromised individual?
Any patient who is on chemotherapy.
So one, you have chemotherapy.
Long-term diabetes.
So you have to say which kind of chemotherapy. So it's going to be those chemotherapy that is known to have prolonged neutropenia. Every chemotherapy is not dangerous. Okay, those chemotherapies in which there is going to be prolonged neutropenia, in those patients that are anti-metabolite therapy, then
Seropositive patients.
no, you cannot say seropositive.
Or anti-retroviral.
No. So when we did talk about the fact that you are having quick suffering. So you talked about what did you say? First thing we said about cancer chemotherapy that is causing neutrophil chemotaxis to reduce. Cancer chemotherapy that is causing neutrophil chemotaxis to actually reduce. When neutrophil chemotaxis is reducing, they are immunocompromised. So you have cancer chemotherapy. Okay. So you have one is cancer chemotherapy. Then you did mention HIV. When you say HIV, you have to say that the CD4 counts are less than 200. CD4 plus counts are less than 200 per microliter. It's very important to say that, because HIV patients per se are not immunocompromised unless their CD4 counts are less than 200. Okay, so this has to come in the same breath. Like how we talk about cancer chemotherapy and those agents that cause neutrophil chemotaxis reduction, we also talk about the fact that HIV having CD4 count of less than 200. Then
Organ transplant patients.
very good. Organ transplant patients who are on long-term immunosuppression, and they are those organ transplant patients, specifically hematopoietic stem cell transplants. Hematopoietic stem cell transplant patients who are on anti-metabolite therapy and therapy that is causing gross immunosuppression. Okay, organ transplant, that is very important group of patients. And when you say organ transplant, you talk about hematopoietic stem cell transplants most importantly. Okay, hematopoietic stem cell transplants. Then
Prolonged steroids.
So actually I explained to you. So steroids, when you say steroids, you have to tell what kind of steroids are we using, what is prolonged, what is the dose. Then only you can say that this is immunocompromised. You can't say a patient who is having a 5 mg of methylprednisolone is to be immunocompromised. They're not. Skin disease के लिए भी तुमको 10 mg prednisolone मिलता है, कुछ होता नहीं उससे. That is not immunocompromised status. So to call it immunocompromised, you have to do it. Whenever a steroid therapy is being done, you have to say 3 levels of steroid therapy. Level 1, level 2 and level 3. What are these 3 levels? These 3 levels of steroid therapy are, if the steroid is being less than 20 milligram, okay, and for less than 3 weeks, okay, less than 3 weeks, and the cumulative dose is less than 600 milligrams, for example, or the cumulative dose is less than 600 milligrams, okay, this is called as level 1. They are normal. They don't have a problem.
Sir, can you repeat less than 20 milligrams?
less than 20 milligram for less than not more than 1 week, not more than 1 week, and their cumulative doses are less than 600 if they are small doses. So if they are at 5 milligrams of methylprednisolone, cumulatively he has received maybe even 10 days, even 100 days, it's 500. No?
This 20 is daily dose.
Yeah. Okay. So when you say that this patient has received say 5 milligrams, 10 milligrams for 3 months, then they become immunocompromised because cumulative dose becomes more than 600. You understand? They don't become immunocompromised still. They just become level 2. Level 1 is non-immunocompromised. There's nothing. These people are like you and me. These people are like you and me, where they are not immunocompromised. They are like you and me. What risk I have, that risk they have. Clear? The next level is if by any chance you have the cumulative doses to be more than 600 or one of this 20 milligrams for more than 10 days. This is level 1. Level 2. Level 2 patients are also not immunocompromised. They are only at a high risk of community acquired pneumonia. They are only at a high risk for community acquired pneumonia. This category of level 2, they are not immunocompromised. They are only at a higher risk of community acquired pneumonia. However, those patients who are at more than 20 milligrams for a long period of time and the cumulative dose is more than 600 milligrams, which is going to occur if 20 milligrams is more, if it is more than 20 milligrams, they are called as immunocompromised individuals because this is the category of patients that will have nocardiosis, that will have pneumocystis cerevisiae, that will have fungal infection, that will have aspergillosis, that will have mucorales, that will have anything, strongyloids, they can have anything. You got the point? All the opportunistic infections.
Duration, sir? More than 3 months.
No, more than
20 milligrams.
more than 20 milligrams or more than 2 weeks. Okay, and or 600 milligrams cumulative dose more, and plus it will be more than that only.
600 milligrams तो class 2 में भी आ रहा है ना more than 600.
ये
These are
देखो
more than 20.
ये दोनों है.
Duration more than 20.
Yeah. ठीक है, clear on this? So you have level 3, which is basically those patients who are. So now you know what is immunocompromised with steroids. You can't just say he's on steroid long term. I know you have to tell level 1, level 2, level 3. Level 2 has community acquired pneumonia. Level 3 has got a risk for opportunistic pathogens. That's why they are called as immunocompromised. So that's why you need to know the definition of immunocompromised status. The definition of immunocompromised status is not that the patient has low immunity. The definition of immunocompromised status is they have a chance of getting opportunistic infections. Okay, you understand? They have a chance of getting opportunistic infections, which I just now enumerated all these different kind of infections that we have. You understand? ये तुम लोग कोई सिखाएगा नहीं है बस. Write it down. Remember this. Somewhere put it and write it down somewhere. Because these questions exam में आते हैं, everybody is looking at the air. I'm telling you that. Okay. Immunocompromised. Just say long-term steroids. What long-term steroids?
Sir, level 3 is more than 20 milligrams or with 600 milligram or higher doses for more than 2 weeks.
Yeah.
With opportunistic infection.
They will have a chance. No, they will have a chance. We are putting them into these 3 categories to know which are the patients that have a chance for opportunistic infections. Because the definition for immunocompromised status says that these are those patients who have a chance of having opportunistic infections. Clear on this? Clear? Now, you might think, what about the CKD patient? What about the very brittle diabetes? What about those patients who have multiple comorbidities, those who have bronchiectasis, cystic fibrosis and all those things? Well, those are relatively immunocompromised, but they are not in the definition for immunocompromised. You understand? They are not in the definition. They are relatively immunocompromised, but they are not in the definition of immunocompromised. Are you understanding? So that's where your clinical status comes in, to understand clinical findings, to understand what this patient could have. What is your examination findings? That is where you think about all these investigations. Why? Because once you're talking about opportunistic infections, you start thinking a completely different set of bacteria, a completely different set of things. So what is the commonest bacteria you see in this subset of immunocompromised individuals? What is the commonest? The commonest stands to be the same respiratory core pathogen, Streptococcus pneumonia. Okay, so this question, if it comes in the exam, EDIC में आता है ये exam में. Exam question आता है. If you're going to give EDIC ना, ये आता है exam, ये question आता है. It says which is the commonest infection you have in in immunocompromised individuals, it is against Streptococcus pneumonia only. You understand? It's against Streptococcus pneumonia only. But they also have a chance of having the rest of the things. They have a chance. Are you understanding? They have a chance in the rest of the organisms also. Clear? Clear till now? So if somebody asks you what are the common respiratory core pathogens, we discussed respiratory core pathogens, gram-positive staph pathogens. We said gram-negative Klebsiella pseudomonas, H influenza. We said viral pathogens, respiratory syncytial virus, coronavirus, and H1N1. We said atypicals like Mycoplasma, Chlamydia, and Legionella. Right? Okay. Clear on this? So here, that means to say, I will have a completely different situation here. In these patients, irrespective of what is happening, I need to send huge amount of investigations. Because I am not going to have this in my usual multiplex PCRs. I require a huge different set of investigations in these cases. Are you understanding? That is where the problem arises. What is to be done? So this is somewhere where I would try to use urinary streptococcal antigen. Okay, because I need to quickly figure out whether Streptococcus negatinic. Problem with urinary streptococcal antigen or influenza, for that urinary influenza, whatever, PCR for influenza is, if you have already a vaccination, there is a chance that that will be picked up. You know, these patients mostly are the ones who are on vaccination. Okay, these are all immunocompromised, already given vaccination, all these things are already done on these patients. There is a problem with that. So you will probably send these patients for higher investigations, PCRs directed towards particular those things, like for example, nocardiosis. You cannot just do nocardia just by sending, you have to think about it. Okay, there is a skin infection, there is nodules that are developing, the lung looks something different. Okay, that is why I am saying this. What is the difference between these patients and your regular community acquired pneumonia patients? Regular community acquired pneumonia patients will come with a classical imaging modality that shows a patch with a classical leukocytosis, with the presence of a fever, and with a WBC count, and all these usual inflammatory markers being high. Unfortunately, the patients of neutropenia, patients of chemotherapy, patients who are having this immunocompromised status will not be manifesting these signs. They do not come with these signs, they just come not okay. They just come not okay. If they manifest these signs, they are very, very difficult and very, very serious. Okay, so when we were discussing pneumonia, we forgot to talk about CRP and PCT. So the question is, do we send a PCT to all our patients? That's the question. We don't do PCTs. Well, can a PCT differentiate between virus and bacterial infection? It can't do that. Nor can the PCT tell you that this is specifically going to do is a sepsis disorder. We know that those patients who are severely septic have a higher chance of PCT being on the higher side. Patient who has a bacterial infection has got a PCT to be on the higher side. But we can't say that I can do a PCT and say that there is no virus. But what I can do with the PCT is, I can actually de-escalate my antibiotics, not trend, I can de-escalate my antibiotics. I can de-escalate. So how do you de-escalate your antibiotics, Sachin?
PCT is on the lower side, less than 0.15.
No, that is not the complete answer.
So we'll look
Yes.
for the
Plus with the clinical.
That is also not the complete answer. So let me give you an example. You have a patient who comes in. Okay, the patient has come in on Sunday morning. You've seen this patient to be community acquired pneumonia, and you've decided that okay, let me put the patient on ceftriaxone and azithromycin. You have done that, and on Tuesday you said a PCT. The PCT comes as 0.1. The patient is getting better. Okay, what do? You stop the antibiotic? I'm asking a question. You just now said this. Yes. Patient is getting better. PCT is less than 0.5. Why do patient point? You just now said this.
single value of PCT we can't decide. With a single value of PCT we won't.
You can decide. So with a single value of PCT you can decide to de-escalate antibiotics, but the difference is in community acquired pneumonia you still need to give 5 to 7 days. Okay, you need to give 5 to 7 days. So the answer is at 5th day we have to convert to 10th day. Whether to go from 5th day to 10th day. That's the question that's coming to me, right? My quinolone macrolide I'm stopping at 3rd day. My quinolone and macrolide I can stop within 3 to 5 days. I don't need to continue that. Right? The reason to give most of these macrolides are also because it reduces inflammation, it causes some immunomodulation it causes. So that's why you also give macrolides. Okay, but at 3rd or 5th day you can stop the macrolide. You don't need to continue the macrolide. Question is, do I continue my antibiotic? Do I continue beyond the 5th day? Do I continue beyond the 10th day? That's the question. To know that, I do a PCT. I can resort to a PCT. If the PCT is less than 0.25, and the patient is clinically improving and done very, very well, then losing my clinical judgment and the PCT and the days of antibiotics, I can actually get off the get off the antibiotic, which will probably help in the long run. You understand? Unfortunately, this doesn't work in neutropenia. Unfortunately, this doesn't work in neutropenia. This PCD like this doesn't work in neutropenia because it's not as sensitive as compared to normal patients. You understand? So we have a problem with neutropenia. We have a real problem with patients on chemotherapy. Okay, we have a real problem. What also is a problem with patients on these cases is that what did we say as the first modality of investigation we had? Imaging. Unfortunately, those patients who are coming in with neutropenia, the X-ray will not show, may not show anything because it is not manifesting that inflammation, it is not manifesting that pneumonia, it doesn't manifest it. That is why these patients you should quickly get what? A CT scan. Okay, very often X-ray will not show, CT scan will show. Very often. CT scan will also give you many clues. What does the CT scan give you? So if the CT scan very often, what have you seen this many times? You do a CT, X-ray, you don't know what it is, you do a CT, you get a pneumonia. You've seen that, right? Similarly, that is why you need to do a CT scan for these patients, not only to diagnose the pneumonia, but also to figure out maybe this is aspergillus. Maybe this is aspergillus. You know, you have small sub-centimeter nodules with the presence of reverse halo sign, which actually shows aspergillus. Huh? Extubate किया क्या उसको? Extubate किया क्या? CT scan, no. So a CT scan will give us an idea whether what are we dealing with. Are we dealing with whether we are dealing with any kind of aspergillus pneumonia or mucorales or things like that, because completely the treatment will change. For example, if you have a patient that is coming with a picture of aspergillus or query, it's looking like nodules or reverse halo sign, it's called as an aspergillus. You see this patient has not, then this patient will completely, or this patient has got features of mucor on the on the skin or things like that. You will completely change. It's no longer going to be ceftriaxone and azithromycin. You will probably need to add another agent, an antifungal. And which is the antifungal you will probably add if you have an immunocompromised status and you are suspecting a fungal infection? Which is the antifungal? Sorry? So you will need an antifungal. That will first of all, how do you think of the antifungal? There are a few tests also you can send. What are the tests you can send? Serum galactomannan. You will be able to send a serum galactomannan. What does the serum galactomannan do? What is the serum galactomannan? It is basically a component of the cell wall of which fungus? Of aspergillus. So it's the cell. It is a part of the cell wall of the fungus aspergillus, and it can also come positive in fusarium and blastomyces and histoplasma and all these things. Also, it can come positive. It can also come positive when you give IVIG, albumin, and blood products, and certain antibiotics. It can come positive in all those things also. So serum galactomannan is not a great test to do in the context of finding something on the scan, in the context of having a situation where this patient could have a fungal infection because patient was on long-term steroids, in the context that the patient has got broad spectrum antibiotics and you get all these things, and all these things are not there, galactomannan may make sense. There again, ball galactomannan is more sensitive as compared to serum galactomannan. Ball galactomannan, sending galactomannan from the ball. Okay, there is another test in antifungal that you normally do, because see, now you have suddenly changed the tests. We talked about multiplex PCR, we talked about already PCR for difficult organisms, and we are now talking about all the more difficult organisms, right? See, we are talking about herpes simplex. You start looking at the body where there is any rash here and there. You're talking of cytomegalovirus. So in a patient of neutropenic sepsis, you will send all of these things because you don't know what it is. You will send CMV PCR, you will send PCR for herpes simplex, PCR, it's a complete PCR that you will send, everything. You understand? Because you want to figure out what's happening here. This is somewhere where you do everything possible. You understand? Very difficult to clinically correlate something. Okay, so there's another antifungal test that you send, another biomarker, which is that? BD-glucan. Now, what is the difference between BD-glucan and aspergillus? What is the difference? One will diagnose mucorales. Okay, whereas galactomannan cannot diagnose mucorales. Whereas BD-glucan is ubiquitous for all organisms. Okay, so here we can either have aspergillus, or you can have mucor, you can have fusarium, you can have scedosporium, you can have trichomonas, you can have anything. Trichosporon, you can have anything, right? Because it's an immunocompromised individual. Since it's an immunocompromised individual level 3, you are looking at patients who can have any of the fungus. Could be trichosporon, could be anything, anything. So what kind of antifungal you give? Till now we talk about broad spectrum. Which is the broad spectrum antifungal you want to give in these cases? It's usually ribosomal amphotericin. Okay, it's liposomal amphotericin which will take care of everything because it's broad spectrum. It takes care of mucor, takes care of everything. Aspergillus takes care of everything. Broad spectrum antifungal, which is liposomal amphotericin. In the event that the patient cannot tolerate liposomal amphotericin for some reason, which normally they do, but if they, for some reason you cannot give liposomal amphotericin, the next drug of choice is isavuconazole because it covers everything. Isavuconazole. Okay, the next drug would be isavuconazole if you cannot go to liposomal amphotericin. Now, if you are certain that there is aspergillus, you have a galactomannan, Ball galactomannan that is positive, you have a histopath diagnosis saying that this is aspergillus, then the drug of choice is voriconazole. Clear? Then if you have a histopath diagnosis saying there is aspergillus, your diagnosis is aspergillosis, you will probably start the patient on voriconazole. Okay, voriconazole is a drug of choice for aspergillosis. Clear? Meanwhile, the rest of the findings will tell you what happens with the CMV PCR is that there is going to be a reactivation. You will find more copies when you say CMV, but whether that is actually causing the problem, it's very difficult. You need an ID expert for that. You understand? CMV, cytomegalovirus, can exist in your body and it can get activated and increase the number of copies. That doesn't mean you have CMV virus, CMV pneumonia or CMV brain problem. You don't have that. To actually figure out whether you have something like that, you need an ID specialist, a histopath diagnosis, and a lot more investigations and clinical investigations to figure out whether this patient actually has CMV problem, for which the treatment is ganciclovir. The same holds good for HSV, where the treatment is acyclovir. Are you understanding? The same is the situation when you look at nocardiosis, where the treatment is Septran. With the treatment of choice is Septran. Okay, so these are the few drugs that will come into our mind apart from the usual drugs when we are actually looking at patients of opportunistic infections. Clear?
Septran.
Nocardiosis. For nocardiosis.
Itself with immunocompromised.
Sorry.
Septran is itself immunocompromised.
Sorry?
Accent, it does it immunocompromised like.
Does it?
It causes immunoconfusion.
No, it doesn't. It's an antibiotic. Septran is a great drug. It is a drug given for UTI. It's the simplest drug for UTI. It's a simple drug that you give for UTI. It's one of the best drugs available in the market for UTI. Septran is an oral antibiotic that can be given, and it also works very well for another bacteria that is there in neutropenic sepsis, which is that another fungus, Pneumocystis jirovecii. Pneumocystis jirovecii. So Septran is a drug that you use for Pneumocystis jirovecii also, which is generally classified by hypoxia more than what the X-ray shows. There will be hypoxia more than what the X-ray shows. Okay, so that is usually Pneumocystis carinii pneumonia, or pneumocystis, not anymore called as Pneumocystis carinii, it's called as Pneumocystis jirovecii. Okay, for which the treatment is Septran, very high doses of Septran, along with plus or minus steroids. So, anything more about opportunistic? You understood opportunistic infections? You understood what is immunocompromised status and how you treat it differently from usual community acquired pneumonia? Now you understood that it's very different. Community pneumonia is straightforward, whereas this is not straightforward. It is extremely difficult kind of task because you need to send everything. Everywhere, everything you have to send because you have to, and you have strong clinical suspicion and it is advisable that every patient who is immunocompromised status, you definitely should involve the right specialty, which is ID. You should. It's not, you don't think that I can treat everything. No. I have an idea, but I want to treat this with the help of an ID. So ID consult is extremely important when it comes to immunocompromised status. It's very important because they deal with such diseases. We don't deal with CMV virus, viremia. We don't deal with all these things on a regular basis. There are people who deal with it on a regular basis. You understand? The suspicion of for the threshold to do investigations are very low. You at the top of the hat to do investigations. Yeah.
Mere finding of CMV is
Not contributory to. Similarly, a mere finding of aspergillus is not contributory. If you just grow an aspergillus, it could be just allergic bronchopulmonary aspergillosis, ABPA. It's just the presence of an aspergillus. That doesn't mean you have to have a histopath diagnosis saying that there is aspergillosis or a huge suspicion, clinical suspicion that this is aspergillosis. Mere finding, because there is no this way that there is a certain clinical feature also. Unfortunately, in immunocompromised patient, there is no clinical feature also. Aspergillosis could be a small indolent kind of fungus that is remaining there slowly growing there, and then we have seen it like that. At the same time, it could be even coming fast and completely going down. So there is no clinical feature that tells, okay, this is this. Here, this is also one of the few cases where you will, in community-acquired pneumonia, we haven't sent TB, no? This is one of the places where you'll be sending sputum for gene expert, sputum for tuberculous bacteria, and sputum for non-tuberculous mycobacterium. You understand? So you'll be sending for sputum for gene expert for mycobacterium tuberculosis and non-mycobacterium species also. This is one of those cases. So, in short, you have to have an area of investigations that you'll be sending in these patients as compared to a community-acquired pneumonia, and a very, very low threshold of escalating of antibiotics and broadening the spectrums. Very, very low threshold for all these things. You know, very, very low threshold for all these things. And the reason, and one of the things that you can do in these cases as a clinician is try to figure out the system involved. Try to figure out the system involved. Is it the respiratory system? Is it the GI system? Is it the urinary system? Or is it the brain? These 5 systems you should be in your mind. Is it going to be the brain? Is it going to be the chest? Is it going to be the abdomen? Or is it going to be the urinary tract? You must think like this. Okay. Only when you think like this, you'll be able to optimize where is what is coming. Because if it's brain, it could be something different. If it's the respiratory system, it could be a fungus. If it's the GI tract, it's going to be gram negative. If it's GU tract, it's something different. So you should be thinking in the system. On an average, we say if the infection is above the diaphragm, you should look at fungus. If on an average, if the syndrome is below the diaphragm, you look at anaerobes as well as gram-negative septicemia. On an average, okay, that's what we normally say. Okay, also we broaden the spectrum and we are worried and calling it an emergency if the duration of neutropenia is going to be more than 7 to 10 days. You understand? So the importance is to confer with the oncologist how long is the neutropenia going to exist. If the neutropenia is going to exist for 4 or 5 days, I am okay, this patient will come out quickly. But if the neutropenia is going to persist for 10 to 15 days, I am in a situation. Are you understanding? Clear on this? So that question is, so that's the first question when this patient came, the first question asked was how long is the neutropenia going to be? Anyone heard me talking? How long is the neutropenia going to be? I spoke to. This is the question that I asked. How long do you expect the neutropenia to remain? So he said 3 days, 4 days. I said then it's okay. You understand? Huh? Clear?